So we're looking at the third and the last of our presentations on the atrial dysrhythmias. And our focus here, obviously, is going to be atrial flutter. Atrial flutter is an example of an atrial dysrhythmia that's generated by a singular re-entry circuit. In other words, a single dominant pacemaker that's generated from a group of cells that has rapid and cyclic depolarization sequences that can initiate polarization. Now, the simplest analogy I can think of for a re-entry circuit would be to imagine a snake that's swallowing its own tail. Every time the snake bites down the tail, it causes an electric shock to pass up through the snake's body, causing it to bite on the tail again, and so on and so on. I'll be providing a more electrophysiological explanation of this when we look at the nodal tachycardias. Atrial flutter is the second most common dysrhythmia in Western population, and is thought to be on the same continuum and very much related to atrial fibrillation. Its incidence increases sharply after the age of 60, and it's significantly more common in men. Like the other atrial dysrhythmias, it's also more common when there's heart failure or chronic obstructive pulmonary disease. And it's not uncommon for sufferers to experience both of these dysrhythmias, sometimes during a single presentation. The re-entrant site tends to depolarize at approximately 300 times a minute and produces a classic sawtooth pattern of electrical activity. In the vast majority of circumstances, this is way too fast for the AV node to be able to transmit, but because the re-entry circuit is more predictable than what occurs with atrial fibrillation, transmission via the AV node tends to be a little more predictable. Now, this often leads to a recognizable conduction ratio between the atria and the ventricles, and the example shown here has that distinct sawtooth flutter-like waves occurring at 300 times a minute, and there's a 4:1 conduction ratio. The sawtooth pattern can be easy to see when the conduction ratios exceed 2:1, but at rates of 1:1 or 2:1, it can be more difficult to recognize. So here's an example of a 2:1. Now, there are two defenses in terms of recognizing this. First is to ensure you watch the rhythm for a reasonable period of time, maybe a minute or so. During this time, there may be variances in the conduction ratio that make the sawtooth pattern more apparent. Secondly, with any tachycardia that has a rate of around about 150, suspect atrial flutter as a likely culprit, and re-examine the atrial activity to see whether it has a steep upsweep, one that you would normally associate with a sawtooth pattern. And if there's two together that match, as is shown here, it's more likely to be atrial flutter. So let's review the characteristics that we associate with atrial flutter. So the principal characteristics are going to be the absence of a sinus P wave, and instead a sawtooth atrial pattern that shows a rate of around about 300 beats per minute. We have said this can be easy to see where conduction ratios exceed 2:1, but at 1:1 or 2:1, it can be more difficult to recognize and requires careful examination of the ECG. The rhythm is often regular, but for some, the AV conduction ratio can be variable. As there are no P waves, there's going to be no PR interval to measure. The morphology of the QRS is not affected by atrial flutter, so we're not expecting to see any changes or variances there. Now, atrial flutter does sit on the same continuum as atrial fibrillation. Its incidence increases with age, and it's more prevalent in men. It's also more common in the setting of heart failure and chronic obstructive pulmonary disease. And finally, the clinical significance. It's going to be very similar to that of atrial fibrillation. It's associated with a higher risk of thromboembolic events and reduced cardiac output when there's faster ventricular rates. This brings us to the final dysrhythmia we're going to look at, which is the paroxysmal atrial tachycardia. By definition, atrial tachycardia is 3 or more consecutive premature atrial beats, and we'll call it a sustained event if it's going to last for more than 30 seconds. Now, there are two types of atrial tachycardia, and we've previously discussed one of them, which is the multifocal atrial tachycardia. That's the one which is characterized by those multiple pacemaker sites, which are producing a variation in the P wave morphology and the PR interval all throughout the rhythm strip. In the case of the paroxysmal atrial tachycardia, this is driven by a singular pacemaker site. Now, this could be a reentry circuit, or it could be just some pacemaker tissue that's been abnormally excited for some reason. In either case, they're going to have usurped the role of the SA node and established an atrial pacemaking site and produced the tachycardia. The incidence of this type of tachycardia is relatively low if we want to compare it with the likes of atrial fibrillation or even atrial flutter. From a diagnostic point of view, is often lumped into that catch-all bucket that's known as supraventricular tachycardias. It does have a slightly higher incidence in the infant and childhood populations, but like most other atrial dysrhythmias, it's still mostly prevalent in those over the age of 65 years. So the distinguishing characteristics of the paroxysmal atrial tachycardia are firstly a very abrupt onset and termination. So if you're lucky enough to see it start, or you're lucky enough to see it end, it's going to start with a single PAC, and then the tachycardic rate is going to be set and won't alter for the duration of the episode. It will end just as abruptly. The other distinguishing characteristics and very typical of atrial tachycardias is that it has a very pointed P wave, and there's going to be a singular morphology or shape for the P wave all throughout the period the tachycardia runs for. The other thing about this rhythm is it tends to be very regular, so the R to R interval is going to be quite predictable. There is little specific evidence on the burden or the significance of these paroxysmal atrial tachycardias. However, as with most atrial dysrhythmias, PAT is going to be indicative of some form of underlying pathology. From a symptomatic point of view, however, symptoms are more likely to occur with the faster ventricular rates, and this is going to be more pronounced where there's either structural or valvular heart disease. So let's wrap this session up with a quick review of the characteristics of these paroxysmal atrial tachycardias. As I said before, the principal characteristics are going to be a regular rhythm with ventricular rates between 120 and 160 beats a minute, although there are, in some cases, very rapid versions of this which can easily reach 240 beats a minute. We've spoken about the abrupt start and termination which characterises these, and that the P wave in this case is going to be pointed, which is very typical of atrial pacemakers, and because of the rates it may appear to be superimposed on the terminal section of the T wave. There is going to be a PR interval, but its duration is going to be determined by the location of the pacemaker site. The QRS tends to be unaffected, so depolarization is still occurring via the AV node, and the conduction is still on a one-to-one basis. The significance we've already discussed, and realise that this is very likely to be rate-related. That's pretty much the end of the section that we're looking at on terms of these three presentations covering the atrial tachycardias. I'll leave you to review the notes that come with this and to go through the textbook to review these characteristics. If you've got any questions, please don't hesitate to contact someone on the teaching team. In the meantime, ka kite.